afternoon, everybody. Very happy to have all of you with us to end a bit the week. Maybe you still have some work after this webinar, but still, it's a moment where we can take some time, maybe to try to look at a very important issue from a wide angle, I would say. And so this is a webinar organized by the COMFORTage project, supported by ETEL, and we are today dealing with an issue which is trying to understand where we are with the political and well, of course, the implied financial choices made by policymakers in dealing with neurodegenerative diseases and dementia in particular. And just a few words about COMFORTage. Is a very large project involving, as you can see, many partners, but it's also very ambitious because basically what it wants to try is to cope with all the different aspects from screening up to personalized monitoring and care for people affected by dementia and the ones who are taking care of them. In this thematic area of the COMFORTage Community Forum, we have foreseen a number of iterations, and we had already two in the past, where we have been trying to discuss with patients and caregivers, and why we have been trying to see also in the second webinar which technology had been developed and were maturing today, which can be used. And so this is the third one. As you can see, we have still 3 more foreseen for next year. In COMFORTage, basically, we believe that we are reaching a point where technology can probably change a number of things and decisions taken by our policymakers, because it's basically allowing us to get out of the vision that we had that people which were unfortunate to be affected by dementia, there was unfortunately not a lot to be done for them. We believe that there is much actually to be done, and much before actually dementia is becoming a real issue, but also probably more and more, and you will see that some of the presenters will focus on some very important aspects. There are very important new developments also, which can reduce the progression of the disease, or and we'll see, or which can deal with the very different facets of the disease altogether. So trying to have an optimal screening and therapy scenario is what we believe we'll be able to do in the next future. I will not go into the details here, but we know that today we have a huge margin of progression possible. And we know that we face a huge problems. We know now that we have 14 identified risk factors which can contribute to dementia, and we can act on most of them. And so we can, we have already a new paradigm starting to say, no, we are not just without any ammunition to fight the disease. We know that, once again, dementia is not one disease, it's several diseases, and some are different, and some can be really dealt with in a very efficient way today. And we know that many of them, as you see, 40 to 45% could have been prevented if we have known early enough. We also know that there is a high time, 4 years in average delay in obtaining a diagnosis. And most of the people actually do only have the diagnosis when it's already late or too late, and the disease is already serious. So we believe that actually dementia is a disease which needs to be dealt with in a very individualized way. But there is more, and you can see here. We know that young dementia, young onset dementia, is also becoming an issue which was not documented sufficiently in the past. And there is now more and more evidence that dementia can have a wide impact on life expectancy, which can be reduced up to about 13 years, which is extremely significant. But also that we also know that the earlier the diagnosis comes, the more years in remaining life and more healthy years can happen. So we also know from the previous webinar that today in most countries, up to very recently, as I just mentioned, most of the efforts were mainly focusing on trying to protect the autonomy of the people affected as long as possible, and some actions for the carers. But basically, there was no, per se, clinical pathway for people affected by dementia in most European countries. And I just want to show here a recent study made in Belgium, which compared the actions foreseen in 4 EU countries for young onset dementia. And as you can see, the landscape is pretty diversified, where we see, for example, in the Netherlands, very high awareness of the problem, with already quite a number of action and specific actions being dedicated to that. While Germany, for example, is only very much starting its journey, and with France and the United Kingdom taking the issue more seriously and having specific initiatives being taken more recently. And if you look at the situation, for example, in Belgium, where we speak about 7,300 people affected, we see that most of the cases happen between 55 and 64 years old. And that represents about 4% of all dementia cases for this country. But interestingly enough, although it's a very new proposed action plan, we see a number of things which we are not so surprised to see, like early detection, professional training, the need to ensure integrated pathways, to have more dedicated solutions for family support and housing solutions, and the need to promote innovation equity. But actually, I looked into the report, and there is very minor reference to technology and what technology can bring today, and what data can bring to this. So I still see a gap, even in very recent studies, in trying to apprehend what technology and AI, let's be clear, can bring for this disease. So today we want to raise a number of questions, and that's the 4 questions that we have in mind. Are current national plans aligned with the recent scientific and technological solutions? What are today the most controversial issues? And what is the political and financial rationale between the choices operated? And how can we better promote innovative and impactful technology in national plans? So that's the 4 questions that will be dealt with by our 6 speakers today. We'll get 3 presentations first, focusing on 3 different perspectives, I would say, and countries. And then we will have the chance to have a panel which is also representing the diversity, as we have both somebody coming from civil society, but also very much involved into the dementia issues, somebody who is trying to implement technology from a public authority point of view, and a technology developer to answer that. So without further delay, and while my colleague is,
You're muted, Luc.
Yeah, sorry. I just need to come back. Voila. I would like to now pass the floor to our first speaker, which is Mercedes Lovoric, which is coming from Slovenia, and she's coming to us with a double hat today, as she's representing both the joint action Jade Health, and also she will tell us more about her country, about Slovenia, and she's coming from the National Institute of Public Health in Slovenia.
My name is Mercedes Lovoric. I'm a psychiatrist, and I'm working in leading. I'm head of expert groups working on dementia at National Institute of Public Health. And today I would like to present my experience working on strategic plans specific to dementia in Slovenia, and to share with you my experience. And I will start with yesterday breaking news. United Nations member states recognize dementia as a leading non-communicable disease, and putting dementia on political agenda is important for all levels, from regional to worldwide. Longer life expectancy is leading to a growing number of older people, and the risk of dementia increase with age is similar with frailty, and this is the fact. But due to manage the increasing phenomena and to help countries to address the challenges of dementia, World Health Organization published a global action plan on the public health response to dementia, and this could be represent as kind of compass to help us to see where to go. While on the other side, Alzheimer Europe and Alzheimer Disease International, with advocacy and making concrete recommendations to EU member states and broader, we can imagine this like a map to see where we are. However, each country prepares its own strategy that meets the needs in that country. And some countries are so successful that they became examples of best practice. For example, in United Kingdom, there are dementia-friendly communities. In Netherlands, approach is person-centered, the right care from the right people at the right place. And in Republic of San Marino, a healthcare system that guarantees significantly faster diagnosis times than international standards. In Slovenia, which is a small country, we are in total a good 2 million inhabitants. However, according to the OECD data, in 2011, we were at 4th place after Japan, Italy, and Germany, with 15 cases of dementia per 1,000 inhabitants. And due to projections, Slovenia could be at 2nd place after Japan in 2040, with 32 cases of dementia per 1,000 inhabitants. In 2023, the government of the Republic of Slovenia adopted a strategy for the management of dementia in Slovenia till 2030, and this is our 2nd strategy. And in 2024, the government of the Republic of Slovenia adopted a 2-year action plan, and this was our first action plan. The next slide, please. Thank you very much. In 2021, Alzheimer Disease International prepared Alzheimer Innovation Readiness Index. And because we cooperated when comparing with other countries, we received feedback that strong political support is extremely important. In fact, United Kingdom in overall scores was the best in rating, and they have very strong political support. And in this situation, we learn 3 things. First, that strategy is just the beginning. The second, that implementation of strategy should be supported by ministries and policy. And third, that we need evaluation. We need a feedback of what is okay and what is not. The second slide, please. So at the moment, we have a second strategy and some useful results due to strong collaboration with stakeholders, from people with dementia to informal caregivers, professionals working with dementia to parliamentarians and policy. And among useful results, we can put relatively stable working group at the Ministry of Health, despite the replacement of 4 ministries and commitment. The group is appointed by the minister. Then we have strong collaboration between Ministry of Health and Ministry of Solidarity Future and other stakeholders. And we have also a specific strategy for dementia and 2-year action plan adopted both by government. And this is very interesting information. Our former president of the Republic of Slovenia hosted a foundation and session of the Council for Dementia Management at the President of the Republic, and a presidential place is now dementia-friendly spot also. And on the other side, National Institute for Public Health, in collaboration with Academy of Science and Art in Slovenia and Spominčica, organized annual national meeting with roundtables. And in these roundtables, we have members of the European Parliament who signed also European Alzheimer Alliance. This is a kind of dementia pledge, a commitment to which candidates to elections to the European Parliament are invited, and by signing which they would commit to supporting the priority treatment of dementia in the areas of health, research, disability policy, and informal carriers, and to joining the European Alzheimer Alliance after being elected. And I would like to say that these meetings are very successful from this point of view, because every year we have almost 100% of Slovenian parliamentarians at European Parliament. And we proposed that if they cannot be present physically, to send us video in which they speak about their commitment about dementia. And on the other side, we have very strong role of Spominčica in Alzheimer Slovenia, and we have actually 500 dementia-friendly spots, and they are all over the country. But on the other side, we have very important challenges. These strategic documents are only base, and we need political stable support in situation and also political will. Bridging the gap between policy and practice, it could be underlying and also financial resources, bridging the gap between social and health sectors, training and long-term planning, infrastructure and logistics. And we need also more health and social professionals and capacities. And we need also evaluation of implementation of strategy and action plans. So solution lies in the holistic, personalized approach that goes beyond the division into health and social sector. Thank you. And there is also joint action, JD Health. This is a collaborative EU initiative to reduce the burden and stigma of dementia through prevention, early detection, and holistic care. This project started at 1st January 2025 and will end after 36 months. And you are all invited to follow the link. We expect best practice to be implemented in several EU countries. However, dementia and frailty are not just health challenges. but also social and economic ones. Over past decades, we have witnessed significant milestones in the EU that have placed dementia high on the political agenda. EU joint action dementia demonstrated that EU recognized the need for a coordinated approach. And the goal was not just treatment, but also the exchange of best practice, the promotion and research, and the reduction of stigma. With European Innovation Partnership on Active and Healthy Aging, the EU stimulated innovation to solve the challenges associated with an aging population, including frailty. And the initiative, next slide, please. The initiative brought the role also to a comprehensive 3P prevention model, and this in primary prevention means and focus on preventing the onset of disease and fostering healthy styles. And example of these are European campaigns to reduce risk factors like hypertension, diabetes. While on secondary prevention, the focus is on early detection and diagnosis and slowing progression. An example are encouraging national screening programs and early diagnosis initiatives. And at third level, the focus is in improving quality of life and access to care and support. But in this case, support is important when disease is already present, and with an emphasis on improving quality of life. In these policies, support access to therapies, technologies, and informal caregivers. The initiative regarding also digital technology is important and is very helpful to understand comparison between medicines and digital solutions. On one side, when we're talking about medicines, usually the time to use medicines is long, but one time this happens, the process of medicines to stay in use is long. On the other side, for digital technologies, this process is diverse because digital products change rapidly. And in case of slow policy cycles, it could be a result also that digital technology became obsolete. And on the other side, there is also a question of ad hoc reimbursement mechanism. This is also the problem, but next, please. But we have also integration of artificial intelligence, and we are witnessing introduction of artificial intelligence and learning machine into all phases of Alzheimer's disease. And there is no more question of whether it will be, but it's already included. And we can think about help of artificial intelligence, enhanced neuroimaging techniques, but also in field of treatment and prognosis. And in case of treatment, it seems that artificial intelligence could be useful in personalized treatment strategies, also with, for example, virtual screening, but also in case of drug repurposing. And also in the field of prognosis, it seems that learning machine can help us in predict disease progression through longitudinal data analyzed and also risk predictions model. The next slide, please. So I have only short summary. it's important that EU policies are moving from a narrow medical approach to a holistic understanding of dementia and frailty. And digital technology is a huge opportunity, but we must also address challenges such as rapid obsolescence and unclear reimbursement mechanism. And a collaboration among all stakeholders is crucial for personalized approach, which is essential for every individual with dementia. And the role of each us is crucial. We must build on the achievement of EU policies, learn from best practices, and also address the obstacles we face. And I think that we should not wait for public mechanism to be solved, but rather to be part of them.
I'm going to show you is the actual scenario of the politics in dementia in Italy, and what is changing due to the changing of scenario to the new achievements on the diagnosis and therapy of dementia. And as you know, respect to Mercedes, I have to say that still we have the second place in the world as the oldest population in the world after Japan's, and we have more than 1 million people suffering of dementia, and 800 more suffering from a preclinic form of dementia, mild cognitive impairment or subjective cognitive decline. So the social impact of this disease is going to be huge in the next years. This is as a socioeconomic impact very, very important for more than 15 billion euro that are necessary for take care of these people, and most of this amount of money is sustained by the families, by the relatives in informal care. So we are in badly need for a complex care challenge for including a multidimensional approach, both pharmacological, non-pharmacological, preventive, and for caregiver support in our territory. This is the actual scenario in Italy. We have more than 500 diagnostic centers called the CDCD, Cognitive Center for Cognitive Decline and Dementia, that are widely distributed in Italy, and these are more specific for clinical and administering conventional drugs for dementia and supportive care for caregivers and rehabilitative care for patients. One last survey, two surveys among CDCD have shown that these new units are not homogeneously distributed in our country, with inequalities between northern and southern regions, with different in facilities and also in technical abilities among them. So we have also a Dementia National Plan that has started in 2014. That is mostly the most important thing is that this plan has never funded by our politicians, and is mainly a governance unit that is mainly devoted to standardize the quality of services and promoting integration among services and in formulating guidelines. This Dementia National Plan has been temporarily founded with very, very few millions in 2020, just to promoting prevention, implemented the National Dementia Plan and promoting epidemiological study. And the board of this national, the National Dementia Board is mainly composed by representatives of the society, regions, technicians, and Ministry of Health. The Dementia National Board has mainly created clinical care pathways for dementia and a document to integrate internet system in the actual management of dementia across the different units in Italy. But most of the works most of the achievements for improving the treatment of dementia came also from Italian scientific society that have created different educational programs, survey, and consensus document in the last 5 years. So we have several documents about the new organization of this dementia care in Italy, new instruments for assessing cognitive and behavioral disorders, and how to implement the use of biomarkers in the diagnosis. And last but not least, also some consortium of neurological clinical research center that is called IRCCS is an organ that has produced several clinical harmonization program in Italy on the adoption of new and common neuropsychological investigation across all the regions in Italy, and harmonization in the processing of MRI in demented people in order to have the same MRI investigation in the different regions, in the different hospitals. The harmonization programs of this unit go far, also including clinics, neuropsychology, biomarkers collection, and nuclear medicine and genetics. The one project that is really important nowadays in Italy is the project Interceptor, that has been promoted by the Italian Ministry of Health and the Italian Drugs Agency. This has been promoted in 2018 in order to have an algorithm to achieve an early diagnosis of prodromal stage of Alzheimer's disease, and in order to have an algorithm to detect patients that are more prone to pass from mild cognitive impairment to dementia. And this project has the enrollment has finished in 2024, and we are going to have the next results in the next months. This is the actual picture, but nowadays we have the arrival of the new anti-amyloid drugs that produce a new challenge for this system, because this new therapeutic, these new monoclonal antibodies has been approved in April and in the end of July of this year, and it has been proved to have moderate efficacy in some patients in reducing the progression of mild cognitive impairment. But in the counterpart, they have relevant clinical risk, above all frequent area, and especially in epsilon 4 carriers people. So this new approach, new biological approach, and new therapeutic approach could result in a significant impact from the economic point of view for the national health system. So the challenge for these new drugs is that this could be administered only at patients that have a diagnosis, not more anymore only a clinical diagnosis of Alzheimer's dementia, but a biological diagnosis of Alzheimer's dementia. And this early diagnosis, biomarker-based, and the need of MRI for monitoring side effect and the apoegenotyping results in an increase of costs in the diagnostic pathway, the diagnostic journey of these patients. And the Italian challenge is that only few of the former 500 CDCD could be able to and accredited for prescribing this kind of diagnostic pathway and these new therapies. And so this is the challenge for the Italian system. The translation of therapies from the conventional therapies to the new therapies requires a redefinition of the diagnostic care pathway, a new organization of the CDCD that mostly are organized in the northern regions with the most the CDCD more with much more requirements of the CDCD there in the south of Italy that are mostly prepared only for clinical diagnosis. So the equity and inequalities among the Italian region is at risk to increase. So the Italian context in these ways is also more complex because the published guidelines of the National Institute for Health that does not recommend the biomarker for the diagnosis of mild cognitive impairment, creating even more confusion in our geriatricians, psychiatrists, and neurologists. Moreover, in Italy, we have a profound modification of the Italian healthcare that is undergoing. Because we are the system is modifying under the Ministerial Decree 77 that define the new standard for the community-based care. This decree create a territorial multidisciplinary hubs for the management of chronic disease that are integrated with primary care and the territorial specialists of services. The CDCD that I told before are included in this healthcare reorganization, but the role of this CDCD internal to the DM 77 must again to be defined, and probably mostly of the less evoluted CDCD could be used for the proximity model of assistance, while the CDCD, the third level CDCD, that have more facilities in biological diagnosis could be equipped with new expertise, new advanced technology, and only this one could be approved and licensed for the disease-modifying therapy prescription and monitoring. So we are going to organize the Italian services for the new drugs and the new diagnosis in referral hub that are these highly specialized centers, and territorial spokes that are the CDCD with minor level of specialization, also including the general practitioner, territorial neurologist, and geriatrician. Of course, referral hub and territorial spokes needs to be integrated in a network in which we have a flow of patients between these two levels of specialization, level of treatment to ensure equity of access to all people and continuity of care from the early stage of the disease, in which probably patients are going to have these new disease modifying drugs, to the most advanced stage of the disease, in which territorial care is more important. And we have no model of this, of course, because the experience of USA, UK, France, and Germany have adopted a different approach. The most important passage that we are going to plan is to create a national registry of patients that are included in this system, and the CDCD and the spoke and hub system, to create a model for the reimbursement of these new drugs, because the sustainability of the economic sustainability of this new scenario need a governance, strictly governance, introducing a balancing between innovation and equity of access. This interoperable national registry will be essential for collecting real-world data of efficacy, to ensuring transparency and monitoring. Of course, also we need to define the criteria to define these new third level CDCDs, which will be the multidisciplinary teams that is necessary, and which will be the minimum requirements for the accreditation of a CDCD as a third level CDCD. And the other points very important, which will be the reimbursement models for the payment. Probably the system payment by results could balance equity of access and sustainability of the health system. Another pillar, important pillar of in this therapeutic path will be the care system and the support of the caregivers. These have an essential support in Italy. I said before that in Italy more than 80% of assistance of people with dementia is guaranteed by family caregivers, and mostly of the cost of this assistance is in charge to the families. So we are facing the risk of burnout of these people, and so we have to enhance the role with psychological support, training, and educational program for caregivers. Just to finish, I want to show you the unmet needs that we are going to face in Italy. We, of course, need a definition of a new patient's journey, and this could be defined in different way for the different types of dementia. For example, different pathway for early onset dementia respect to late onset dementia. And also we have to define a shared patient journey with harmonized tool and biological diagnosis similar in different CDCD in the north and the south of our country. And the other important point is the training and educational programs for all the professionals, the actors that are going to work in the CDCD organization, and also I repeated the minimum mandatory requirements for the CBCD that will manage the new disease-modifying treatment. Which will be the patients that we are going to have these new treatments? We don't know. So we don't have documents to predict the number of potential candidates for these two new disease-modifying treatment and to new biological diagnosis. That this is necessary in order to better prevent and define the distribution of the highly specialized CDCD in the country, and to have a good economic program for sustain these kind of actions. And of course, we need to plan the appropriate monitoring of patients undergoing this treatment. So, just to finish,
we need to close because we have been late. Thank you, Danilo.
This is the last slide. So, the new frontiers and the future perspective are the probably pragmatic trials in real world, this multimodal approach, the use of new biomarkers, and probably in this Italy will have an important role in the future. Thank you for your kind attention.
I'm Christina Niederer. I'm Professor of Design from Manchester Metropolitan University. That's the sister university to Manchester University, not to be confused. So it's really interesting for me to sort of think about this question of how we understand political, of course, and financial choices made by policymakers in supporting patients and carers affected by dementia and frailty, especially with regard to prevention and care. So I want to talk a little bit about the broader policy context in the UK, which in general is, like this discussion already has suggested, policies are moving towards prevention. But what do we mean by prevention, and how can that be progressed, but also supported by care for those for whom prevention is not has not been effective, or not been in time, or whatever it might be. So just to sort of go through a little bit of how key things in terms of dementia policy that are happening. We've got APPGs, that's all party parliamentary groups that that work on specific themes. So we've had one on dementia, which has taken a rights-based approach, and based on that provided a report supporting the rights of dementia within the disability legislation in line with European laws. Then we have an APPG on arts, health and well-being, which produced a review in 2017 that is not specifically on dementia, but has included work around dementia and how to support people with dementia through creative arts. This has morphed into an APPG on creative health, which was provided a new report in 2024. And then underpinned, sort of policies underpinned, of course, first of all, by the national health system, the NHS, and its care services, so both health and social care services organised centrally. And then other local organisations and charities, various organisations. So Centre for Ageing Better has, for example, produced some really useful principles that are looking very holistically at all the people in general. It's that little colourful flower at the bottom. And then charities like Age UK, Alzheimer's Society and Dementia UK, who do the lion's share in many ways of the care and support, research and individual support for people with dementia and their carers. Here we go. And I just want to introduce you to a couple of details. One is the Alzheimer's Society's vision for 2050, where Alzheimer's disease, it's my summary of it, is cured or treated by 2050. Prevention is increased and affordable disease protection available, faster diagnosis, next generation treatments, quality of life, living with dementia, So focus on living rather than dying, which is a key issue of the fear of dementia, which causes so much of the stigma and the delay in getting a diagnosis. So through population level screening, leading to understanding and managing risks of dementia, accessible to all, an increase in the confidence in treatment and support will reduce stigma, leading to more early diagnosis and better quality of life. And then the final one, which for me as a designer is particularly interesting, is the state of care. Most people will get support through community and home-based care. And that's something that is of particular interest of how we can manage that. So key issues to living well with dementia, as we've heard, are frailty. People get frail, perhaps have balance issues, those kinds of things. We've got loneliness. Sorry, that picture's in front of the screen. Loneliness and associated stigma with the diagnosis, both stigma by others and self-stigma of people who are being diagnosed. And from our previous projects, we know people have told us a lot of those things, of feeling that they're worthless, that they can't take responsibility anymore, and that have taken them into depression. The diagnosis has taken people into depression anywhere between 1 and 3 years on the whole. And that's quite difficult because that makes people reticent to engage socially, and that makes the symptoms even worse. So that means things like accessibility, activities for people that are suitable, community engagement, suitable environments, suitable services, respect, social inclusion and participation are really, really important to facilitate well-being, and also to improve people's sense of agency, of being able to change something about their fate. So general prevention and care support that we've got in the UK, and by no means that is comprehensive, but I think it's some of the key ones. So we've got advice through the general practitioner, so that's the local practice that people register with and go to a doctor with any issues. So first port of call in the UK is called the GP. Then we have Age UK, the Alzheimer's Society and Dementia UK, where people can go for advice, but they can also be referred to through the GP or through the memory assessment clinics. Age UK particularly provides care and support, dementia cafes as well. We have a service that's called social prescribing, in recognition that social engagement is particularly important for people, and that can happen through the GP. Companionship programs, in recognition of the importance of social engagement, is offered now by the Alzheimer's Society and currently developed further, and then the Dementia Friends, which you already mentioned earlier. And here's just a brief overview from Age UK of their strategic priorities, which really reflect some of those things in terms of the befriending service, Men in Shed, which is around hobby, sort of leisure activities, doing things, feeling useful, but also being socially engaged, counselling, musical memories, music always very, very important, dementia day opportunities such as dementia cafes and so on. So I won't stay there because I know we're a bit short of time. So in terms of the state of care, as I've mentioned, where do the creative disciplines fit in? We've got the APPG on creative health, and the review defines creative health as creative approaches and activities which benefit which provide benefit for our health and well-being. And they talk about very generally about creative approaches and activities, which are very broad. It came out of the arts-based approach, which often is related to art therapy, and training in this kind. But I want to highlight, being a designer, I want to highlight design for health and well-being in this context, which has been rather less recognized, perhaps because it is somewhat younger, but it is no less important. And I want to talk a little bit about why design, because design is everywhere. The computers we're looking through, connecting through the screens, the design of those screens, the chairs we're sitting on, the tables, the clothes we wear, the houses we sit in, the services, the interactions that we have, all are mediated by design. So design is ubiquitous, it's everywhere. And that makes it so incredibly important. Quite often it's transparent, and by that we mean it's overlooked. If it's seamless, we don't notice it. And that's one of the, that's usually when design is good, because if you notice it, it's usually because it's not well done. When things break down in many ways, but sometimes they're even better and they give us delight. We call that the delight factor. That's what we're aiming at, where we notice it in a positive way. So design can help us make things better, interactions, services, products, and environments. And the process that we employ for that, we call co-design, which is person-centered. It puts the user or the person, and we deliberately don't talk about the patient, the person. We're trying to look at the person as who they are, with their wishes and dreams and aspirations, to provide a multi-perspectival and solution-focused perspective. And so, yeah, we tend to use the power of design for prevention to increase well-being and quality of life and to reduce stigma. I'm heading the Do Well Design for Health and Wellbeing Research Group, and our mission is to promote creative collaborative practices to focus on holistic, solution-focused and integrative approaches and policies to help improve well-being and social change. We have had a number of projects, including Mind, Design for People with Dementia, which was a European RISE grant from 2016 to 2020, and the I Do service, which was a Marie Curie Fellowship from 2020 to 2022, followed by an ESRC project on the same topic. And I want to focus on these two projects today, just very briefly. Look, do let me know when I'm sort of 2 minutes to the end, because I can't see a clock and I've left my phone somewhere else. So our approach is person-centered, seeking to destigmatize dementia and other disabilities, promote well-being pre and post-diagnostic, with particular focus on emotional well-being of people, social well-being, social engagement, social contact, and to allow people to feel a sense of empowerment, which gives them a sense of value and which can hugely improve how people feel. And the aspect perhaps to add to is, if people are confident, they can do a lot more. And I'll say something to that in a moment. So the first project that we sort of successfully developed out of the Mind project was this board game. It's a mindful life storytelling board game, which was designed particularly for people at a stage of diagnosis, after diagnosis, when people felt that there was not enough support. A lot of it was focused on very serious aspects like making your will, power of attorney, how to afford your healthcare that we've just heard from our previous speakers. And we wanted to help people reorient to think about who are they and who do they want to be, so that they are a person still and not just a person with dementia. So the game itself was developed with people with dementia in 4 countries. So we deliberately worked with people with dementia. Here, this picture shows the Public and Patient Involvement Group at Intras, our health and care partner in Spain. And the game itself became a life story path that you can see divided into decades, indicated by the colors, with 6 fields on each for each decade, which offers aspirational questions. So it takes people through the well-known aspect of reminiscence into the future, into the present and future, because that is the thing that tends to be really difficult for people with dementia, to think about the present and the future, because they're very scary. And so in this convivial context, it allows people to voice their fears, but also voice their aspirations. And we found that it was particularly successful in peer groups, in daycare groups, that allows people to voice those things.
Last
So
2 minutes, Christina.
Yeah, great. So it was evaluated with 50 people across 4 countries in the UK, Germany, Spain, and the Netherlands. And it's on the market, and you can also read the reference to our paper. It was originally called This Is Me, so the paper is called This Is Me, whereas the final published version is All About Us. And we're hoping to get it into the Spanish version out into production over the next year as well. We had another, and I'll skip a little bit over this, but I'll just mention it, Living the Life, a reflective booklet, which offers people, again, an opportunity in a very simple way to look into how can they manage their everyday lives, supported by mindfulness, very simple 1-2 minute mindfulness exercise that they could choose to help them to relax and reflect on what's going on in their life and how they can take charge of it to manage it. I want to say just a little bit more about this project. I Can Do service is a volunteer service with people living with dementia. Most volunteer services are to support people with dementia. This service that we're developing is helping people with dementia, with early stage dementia, if they find that they can't work anymore, or perhaps they're retired, but they don't feel confident to go out, to provide a supported service where they can go out and volunteer to feel useful and to feel that they still have value. And we've had 2 trials, and in particular in the second trial, we had 1 participant who gained so much confidence, she managed to gain back her driving license, which people lose in the UK with a diagnosis. So she got her driving license back. And she managed to volunteer in 2 places, including as a school reader for children to help them improve their reading skills. And we have a little video on this, and I can post a link to this later. She spoke for us in the symposium at the end of the project to say how much it had helped her improve her life. And I think it's a very moving account that she's provided us with. So this is under development. And one of the things is that we're supporting about bringing it back to design is the process that we're using that I've mentioned, but also to make things accessible. So all our supporting booklets are very much designed in an accessible way through color coding, through simple layouts, big fonts. So we always work with people with dementia to ensure that they're designed in the right way. And coming to technology, underpinning the service, the intention is to have a technology underpinning the service to provide the communication systems. And again, they need to be very, very accessible. So I'm just about to finish, Luke. So we have produced a number of guides and recommendations, which you can access through our website, designingfordementia.eu, and one of which has been included in the World Health Organization's Global Dementia Observatory Knowledge Exchange platform. And so final thoughts, digital use. Most participants that we've been working with wanted less focus on digital and technologies, but they also recognize that they can be very useful tool to support accessibility, information sharing, but quite often it needs careful consideration to pair with a non-digital offer for accessibility reasons. So we have a change. There may be a change within a decade or 2 because of the change in digital literacy, which needs to be considered. But in any case, we need to focus on accessibility through user experience and service design. And I want to sort of rephrase the question that you asked at the beginning, where you asked, how to promote more impactful technological technology in government plans. I would like to rephrase as how can we promote more impactful design in government plans to support prevention, diagnosis and care support towards holistic well-being.